Hello and welcome everyone to our February info session. These sessions are offered under the CMS Measure System contract led by Battelle. I am Kate Buchanan, and today's session is on digital quality measures. I'm fortunate to be joined by Lisa Anderson from Mathematica and Grace Glennon from Yale Core. Next slide. These info sessions are part of an ongoing effort to engage measure developers and other stakeholders in quality measure topics, an effort that also includes the MMS newsletter, special announcement emails, public webinars, and routine updates to the Measures Management System Hub. Do you want to take a minute and cover a few housekeeping items? First, today's session is being recorded. Second, all participants will be muted during the call. We will have an opportunity for Q&A at the end. And in order to ask a question, we will ask that you use the Q&A function on the bottom of your screen. Third, we will share resources throughout the webinar in the chat window, and you should see a download for the slides there right now. So it should say link from for today's slides, and you are able to download the slides then. Finally, the recording of today's presentation will be put on the CMS YouTube page and the MMS Hub at a later date. So we can move on to the next slide. Today, we're going to hear an overview of digital quality measure transition goals from Grace Glennon, and then move on to dQM specific specification considerations with Lisa Anderson. Next slide. This presentation is current at the time of publication. Since Medicare policy changes frequently changes, we have links to source documents in this deck for your reference. This presentation is not intended to grant rights or impose obligations. It may contain references or links to statutes, regulations, or other policy materials. And the information provided is only intended to be a general summary. It is not intended to take place of either the written law or regulations. We encourage our viewers to review the specific statutes, regulations, or other interpretive materials for a full and accurate statement of the contents. Next slide. So as you know, we ground our info sessions within the measure lifecycle. Today's presentation will focus on the specification phase, which you can see highlighted here. And if you want to learn more about the measure specification overview, that link has been put in the chat. So I will now turn it over to Grace.
Thank you, Kate. Hello, all. My name is Grace Glennon. I'm a health outcomes researcher at Yale Core, supporting CMS in their efforts to advance towards digital quality measurement. Before we jump into the main content for the discussion today, presented by Lisa Anderson from Mathematica, I will provide a brief overview and perhaps a review for many of you on CMS's broad goals for transitioning to digital quality measures and how data standards will be leveraged for that transition. Next slide, please. CMS has continued to evolve their quality measures over time, starting with traditional paper-based measures, then introducing eCQMs using data from EHRs, and now transitioning to digital quality measures, which can use additional data sources beyond just the EHR and streamline the quality measurement data flows. The goals for transitioning to digital quality measurement include developing digital quality measures that leverage standardized, interoperable digital data, reducing burden associated with current mapping and reporting workflows by leveraging FHIR and FHIR APIs that are already required for interoperability, providing usable and timely data coming from multiple digital data sources to support high-quality care, and as always, producing reliable and valid measurement results that are common across multiple programs and payers. These efforts all build off of recent and current activities, such as the 2020 CMS and ONC rules requiring providers and health plans to make data more accessible for interoperability, CMS's Meaningful Measures 2.0, ONC's USDI and USDI Plus initiatives, and HL7 FHIR Accelerator work. Next slide, please. So CMS is continuing to refine the dQM definition and has solicited a lot of feedback in recent requests for information in the IPPS and PFS rules to ensure a definition is constructed that is clear to the community and describes dQMs thoroughly. Here on the slide is the current working definition. So dQMs are quality measures organized as self-contained measure specifications and code packages that use one or more sources of health information that are captured and can be transmitted electronically via interoperable systems. Data sources for dQMs can be broad and include EHR data, as well as patient-generated data, data from registries and HIEs, data from instruments, among others. Next slide, please. To achieve the goals of digital quality measurement, CMS developed a strategic roadmap for advancing to digital quality measures. The dQM roadmap focuses on strategy and actions in 4 key domains: improving data quality, advancing technology, optimizing data aggregation, and enabling alignment of measures, data, and tools. Each domain requires evolution of technical components, policy considerations, and engagement with stakeholders. Today, I'll touch mostly on improving data quality, though all of these domains are equally important to the transition. Next slide, please. The Digital Quality Measurement Strategic Roadmap and CMS's plans and activities for transitioning to digital quality measures aligns directly with the National Quality Strategy. Transitioning to digital measurement, where data used for measurement live on to serve the healthcare system to provide better care, can support embedding quality throughout the patient care journey, advancing health equity, preventing harm, and embracing the digital age, as outlined in CMS's National Quality Strategy. Next slide. It's also important to note that data standardization is the foundation to effective and lower burden digital quality measurement as one use case of that data in a learning health system. CMS is focusing on leveraging standardized interoperable data for digital quality measures. In a learning health system, digital measures should support quality improvement, clinical decision support, and inform and are informed by clinical guidelines, research, and surveillance. Standardized data are used throughout the cycles in a learning health system, which include surveillance activities to derive evidence from data, evidence being translated to clinical guidelines and clinical decision support, data and guidelines being used to transform clinical care, quality improvement activities, data being interpreted and applied to support measurement and analytics, and results based on that data being reported out. These actions and learnings are bidirectional and lead to improved patient outcomes and delivery of high quality care for patients. Next slide. By standardizing data into a common agreed upon format, including data terminologies and models, we can enable data to flow across existing institutional silos. This in turn provides a platform to improve the quality of data as individuals in the healthcare ecosystem securely gain access to a wider array of information, less constrained by those existing data silos. As the ecosystem establishes agreed upon data standards, there's the ability to align data requirements across quality programs within CMS, among other federal partners, and beyond the domain of quality measurement. Data standardization in turn allows for the data to be usable for multiple use cases, including at the center, patient access to their data, as well as for measurement, analytics, research, and public health. Next slide, please. So as I've been discussing, the advancements in data standardization provide an opportunity to continue to evolve quality measurement. At the current state, there's still a number of limitations with the implementation of eCQMs. Many eCQMs are not plug and play and do require implementers to read and interpret specifications, do local mapping to pull data for each measure. There's some limitations around the current standards, and some eCQMs still require changes to workflows to support extensive data collection for a variety of healthcare data requirements. There's an opportunity for future state dQMs to leverage advances in data standardization, in FHIR, and in technology to improve quality measurement and allow for dQMs to be implemented in a more seamless way. So CMS is focused on leveraging interoperability data requirements for standardized APIs and certified health IT set by ONC's 21st Century Cures Act final rule, including the use of FHIR and USDI, as well as the new USDI Plus initiatives as vehicles to support modernization of CMS's quality measure reporting. We'll talk more about FHIR on the coming slide, but the USDI is a set of data elements ONC has developed as a foundational data set that must be made interoperable for patient care. Those standards don't include all data necessary for measurement at current, but CMS aims to continue to collaborate with ONC to align as much as possible and build on the USDI for measurement, expanding only where necessary, for example, via the USDI Plus initiatives. By using data and building on those common data in common formats with aligned definitions as a basis for quality measurement, we begin to enable more automated data transformation and transmission. It also provides a common basis for valid and reliable data mapping and supports auditing of data capture with less novel effort required. Finally, it limits the extent to which data capture expressly for the purpose of quality measurement may interfere with appropriate and routine clinical care. Next slide, please. So now I'll just touch a little bit more on the FHIR standard, or Fast Healthcare Interoperability Resources. FHIR, coupled with other standardization, technology, and alignment activities discussed a bit here today, has the opportunity to do a few things. First, help reduce burden. Burden reduction is something that has been difficult to achieve in the current ecosystem due to some of the technical limitations and how the requirements work. With FHIR, CMS can align quality measurement standard with the industry clinical exchange framework, allowing for data to be available in a consistent format, leveraging standards-based APIs. This also allows for more automated data retrieval from EHRs and can enable the provision of more real near-time feedback on quality measure results to providers, again, to feed into that learning health system. FHIR also simplifies data mapping. Current eCQMs map to a few different standards and models. FHIR improves the alignment between eCQMs and dQMs and other use cases, including clinical decision support. FHIR can also promote interoperability as well as helping to align the data exchange requirements for quality measurement and reporting with interoperability standards used in other health exchange methods. There's also flexibility of the standard that allows access to an exchange of information suitable for use in a variety of contexts. Also, I think important to note, FHIR is being embraced by the commercial community and big tech, and they are building on the same base data model. So although this discussion today does focus on quality measurement, CMS is exploring use of FHIR across the agency, all aligning on this broader interoperability. So with that, I will now hand the presentation over to my colleague from Mathematica, Lisa Anderson, to present on converting QDM-based eCQMs to the FHIR standards as a step CMS is taking as part of this transition to digital quality measurement. Lisa?
Great, thank you, Grace. I am Lisa Anderson, a clinical quality informatics lead at Mathematica and the FHIR task lead for the FHIR conversion work for our measure developers. In the next section of this presentation, we will share an example of creating a dQM. Specifically, we will provide an overview of converting the existing QDM-based eCQMs used in CMS programs to the new FHIR standard. This section of the presentation is not intended to imply that all dQMs must be specified in this way or imply that our experience will be your experience. This section is instead intended to provide one example of how CMS is transitioning to dQMs and highlight some of the challenges and considerations in conducting the work. Next slide, please. First, let's review what an electronic clinical quality measure, or eCQM, is, how it is currently specified, including tools, standards, and terminologies. Then we will discuss how this can be translated into FHIR. The current definition of an eCQM is a clinical quality measure expressed and formatted to use data from electronic health records and/or health information technology systems to measure healthcare quality, ideally data captured in structured form during the process of patient care, which varies from a dQM, which can pull data from various digital sources, as previously mentioned by Grace. There are eCQMs for eligible clinicians used in CMS programs such as the Merit-Based Incentive Payment System, or MIPS, and eCQMs for eligible hospital/critical access hospitals used in programs such as the hospital inpatient and hospital outpatient quality reporting programs. eCQM specifications and associated materials can be found publicly available on the eCQI Resource Center. CMS created the eCQI Resource Center as a one-stop shop for eCQM-related information. Next slide. As CMS moves to dQMs, all measures will continue to be driven by standards. Current eCQM standards include QDM, or the Quality Data Model, CQL, or the Clinical Quality Language, and HQMF, which is the Health Quality Measure format, as you can see in the visual to the right of this slide. HQMF is used by all eCQMs and standardizes a measure's structure, metadata, and logic to provide consistency across quality measures. CQL is used to express the measure logic, and QDM is the data model. These standards are also integrated across tooling used to develop and update eCQMs, including the Measure Authoring Tool, or MAT, and Bonnie. It is important to note that standards will undergo continuous improvements, which will eventually trickle down to updates to the measure tooling to ensure alignment. And those updated standards in the tooling are used in the eCQM annual maintenance cycle to remain relevant and up to date with current clinical guidelines and standards. Next slide, please. As mentioned in the previous slide, here are the current eCQM standards that serve as building blocks for an eCQM. We see the QDM, CQL, and HQMF. We are transitioning to new standards listed in the graphic on the right side of the slide. QDM is transitioning to the QI Core profile. CQL remains the same, we're still using that. And HQMF is transitioning to the FHIR eCQM. On the bottom are the reporting mechanisms. Currently, eCQMs use QRDA1 and QRDA3 standards for reporting EH and EC respectively. As we move to FHIR, reporting moves to the dEQM individual and dEQM summary, which are based on the FHIR standard. Next slide, please. One key standard that will be changing from QDM to FHIR is the data model itself. Currently, eCQMs use the QDM to build the measure logic. In transitioning to FHIR, data will now be modeled in QI Core. For the purpose of our quality measures, we are using the QI Core profile in FHIR. Next slide. The process to convert an eCQM from QDM to QI Core FHIR includes 4 basic steps. First, use the QDM to QI Core R4 mappings found in the QI Core implementation guide to perform the initial conversion. Second, use the QI Core implementation guide to refine and add additional measure-specific context to the logic by evaluating additional FHIR elements. Third, value sets should be applied to the converted logic and evaluated for applicability. Fourth, test cases for clinical scenarios or covering edge cases should be created to test the converted logic. At the bottom of this slide, we have a very simple example of a QDM data element. Intervention performed is the QDM data type, and suicide risk assessment is the value set. Together, these make up the data element in the context of the quality data model. Over the next few slides, we will use this QDM data element as our example to walk through the 4 conversion steps. Next slide, please. As mentioned previously, moving forward, eCQMs will use the QI Core profile. Currently, we are using QI Core version 4.1.1 profile. But what exactly is QI Core? QI Core is a version-specific data model built directly on top of FHIR resources. This includes US Core and base FHIR resources. For additional information on how QI Core is built on FHIR resources, we recommend visiting the FHIR page on the eCQI Resource Center website. You are probably curious how we get from a CQL QDM measure to a CQL FHIR measure. In the HL7 Quality Improvement Core Implementation Guide, referred to as the QI Core IG, you will find a mapping of QDM data types and attributes to the QI Core resource and elements. Each QDM data type is mapped to a QI Core resource, and each attribute maps to an element or elements. The links in the mapping will direct the user to the QI Core resource page, where the snapshot table can be reviewed and/or the detailed description of the element. The initial conversion from QDM to QI Core will need to be performed for all measure libraries and shared libraries used by the measure. The measure authoring tool, or the MAT, which is the tool used today to specify QDM-based eCQMs, has functionality to convert a QDM-based eCQM to FHIR. While this provides a start to the conversion, essentially applying the QDM to QI Core mapping, there is still some manual work to be performed, which we will discuss further on the next slide. Next slide. Oh, there we go. This next step is to review the QI Core Implementation Guide and evaluate if there are any elements that do not map directly from QDM. This image is displaying the snapshot table for the procedure resource. This table is one of the primary sources of information when evaluating a QI Core resource and covers the cardinalities, descriptions, and constraints for the resource and resource-specific elements. Some examples of elements that should be considered include the status elements for FHIR resources like condition, procedure, and encounter. Review of the resource snapshot table is a manual review step where it is important to understand the intent of the measure and the QI Core model, as all elements may not be necessary for a particular measure. Elements should be added to refine the measure logic. Next slide, please. From this example, you can see the QDM data type is intervention performed, highlighted in yellow and green on the left, in the current QDM-based eCQMs. This QDM data type maps to a FHIR resource of procedure. To capture the intent of this logic, which in QDM requires that the procedure of a suicide risk assessment be performed, the FHIR element of status with a code for completed, highlighted in green, was identified for addition. Overall, the key is to keep the intent of the logic regardless of the data model. In the example mentioned here, both data models express that a suicide risk assessment was actually performed. Next slide, please. Value sets are an integral part of a measure, regardless of the data model used to specify the measure, as they contain lists of codes from standard vocabularies that define clinical concepts and facilitate effective exchange of health information. Based on our work to date in converting measures from CQL QDM to CQL FHIR, we have not identified any instances where measure-specific value sets will need to be changed. Elements added to the measure after evaluating the snapshot table in the QI Core IG will require the addition of either a value set or a direct reference code. These may be an addition of measure-specific value sets or direct reference codes, or they may be HL7 specific value sets or direct reference codes. It will be dependent on the element and measure syntax. The QI Core IG does prescribe vocabulary bindings or constraints and should be observed when converting a measure specification. Next slide, please. The purpose of test case development is to ensure the logic is performing as expected. Because the QDM measure is the basis of the FHIR measure, regardless of the data model, at a minimum, the same test case scenarios and edge cases should be tested. As such, the QDM developed test cases will be the basis of QI Core test case development. The CMS-sponsored tools, FHIR and MADI, have some functionality to assist in the conversion of test cases. In using the QI Core standard as the data model, there is a requirement for the test cases to be FHIR compliant. This means that each test case must include all elements that have a cardinality lower bounds of 1, even if the element is not found within the measure logic. This is slightly different from the expectations for QDM test cases. For the purposes of the work we are doing, the expectation is the same from testing in Bonnie QDM and Bonnie FHIR and/or MADI. The goal is to still achieve 100% coverage of the logic and 100% passing for each measure. To meet 100% coverage, new test cases will need to be added to address any new elements introduced from the conversion from QDM to QI Core. Next slide, please. From an eCQM FHIR standpoint, there are a few upcoming milestones for dQM conversions. We are currently working on the conversion of all CMS programs using a new tool we mentioned earlier, the Measure Authoring Development Integrated Tool, or MADI. MADI is a tool that combines what historically the MAT and Bonnie have done, which is to author measures and complete test cases all within one tool. We will complete specification, test logic with test cases, and conduct a logic and standards review across all measures. Once those conversion steps are complete, CMS will hold a public comment period. This will occur for both eligible clinician and eligible hospitals measures during different timeframes and is an opportunity for information gathering. Vendors and implementers will be able to provide real-time feedback on the FHIR eCQMs for measure developers to review and consider in their conversion process. The second upcoming milestone is CMS inpatient hospital quality reporting, specific voluntary and mandatory reporting once the FHIR eCQMs become active and published. Other CMS programs, such as MIPS, will follow with implementation in the coming years. As CMS moves through a thoughtful and steady follow-out of FHIR eCQMs, CMS will need to dually maintain and publish the current QDM-based eCQMs, as well as the FHIR-based eCQMs on an annual basis. Next slide, please. Now that we have discussed the workflow of converting a use case to eCQM FHIR, what does this mean for you? What information and skill sets are needed to begin FHIR eCQM conversions? For starters, a strong understanding of QI Core and QDM to QI Core mapping is needed to make sure the measure intent is preserved through the conversion process and that a single measure specified in these two data models is measuring the same thing. Second, a strong understanding of how data is stored and clinical workflows, as this will impact the feasibility and burden on implementers when measure changes are made. And lastly, knowledge of the standards being used through the conversion process feeds into the first 2 points and impact how implementers report the measure. As CMS and others expand dQMs beyond eCQMs to include other measure types, for example, clinical quality measures or CQMs or claims-based measures, new challenges or conversion steps may be required. These conversions may pose different challenges as they are not currently structured using a formalized data model and may not have clearly defined data elements like we have today for eCQMs. Next slide, please. On this slide, you see a couple of resources that may be helpful as you embark on your own QDM to QI Core conversion journey. At the very top, we have the QI Core implementation guide that we have referenced throughout this presentation, and also a link to the QDM to QI Core mapping. We also have links to the digital quality measures page on the eCQI Resource Center, as well as the CMS HHS YouTube channel, and a glossary of all the eCQM and FHIR acronyms, some of which may be new to you that you heard today. Next slide, please. We also have some additional opportunities for collaboration on this journey. Anyone can join the QDI user group, which was formerly named the QDM user group, as well as the Cooking with CQL webinars, both which occur monthly. Exact details for these events can be found on the eCQI Resource Center. The FHIR collaboration and eCQM working group meetings are intended for measure developers and occur weekly. For both of these calls, measure developers can email eCQM@icf.com to get added to the distribution list to be included in participation. I am now turning it over to Kate Buchanan. Thank you.
Thanks, thanks so much, Lisa. And we can move on to the next slide. So we do want to encourage you to submit questions using the Q&A feature. I will note that there are some questions that we may need to follow up on after the webinar, so they may not all be answered at this time. I also wanted to note that there is an opportunity to provide some feedback. Some of the questions are what questions can we answer on the transition to eCQMs in FHIR, dQMs, and then also feedback on what topics would be helpful to cover in the future as quality programs transition to dQMs. I will say we've received a couple comments about timing of the transition, so I thought maybe we could address that at the top, and then we can move into some of our other questions. And Grace, I don't know if you would be the best person to talk about timing.
Sure, I'm happy to. So I think, in general, CMS has not yet set an exact timeline for the transition to, full implementation of FHIR eCQMs in programs. However, as Lisa noted, there are specific steps that CMS intends to ensure occur before any voluntary or mandatory reporting of FHIR eCQM. So that includes, the actual conversion efforts, as Lisa was mentioning, for eCQM specifications and the opportunity for gathering comment on those technical specifications themselves, testing, including, end-to-end testing of FHIR eCQMs to ensure that the data flows and workflows are appropriate before implementing any FHIR eCQM reporting. And, CMS has noted intention to, include some sort of voluntary reporting prior to any mandatory reporting. And of course, all of this would be proposed through CMS rulemaking prior to any implementation. I think there's also a question about the actual timing of conversion activities. And I think, we can note that CMS eCQMs have begun to be converted from QDM to FHIR, as Lisa was, outlining the processes. So those actual conversion efforts have begun. Lisa, did you have anything to add on that point?
No, thank you, Grace. You hit the nail on the head.
Okay, excellent. So speaking of the QDM to QI core mappings, are there resources or ways that people can connect with the entity that maintains those mappings if they have an issue?
Yes, and this is Lisa. I can take that one. So there are actually two channels, since the FHIR standard is based out of HL7, that are opportunities to ask questions or identify issues related to it. So if there is an error or an inconsistency in the QI core implementation guide, and specifically the mapping page, the best approach would be to create an issue in HL7's JIRA, which is different from ONC's JIRA, just to point that out, to give specification feedback. And Jess Sadler will paste that link into the chat for the FHIR specification feedback on the HL7 site. The other channel, if it's more of a question about the mapping and the best approach to take, especially if it's coming from a measure developer or someone who's trying to understand the mapping maybe a little bit better, would be to create an issue in the QDM project in the ONC JIRA tracker. So that's what many of you are familiar with today for eCQM. So the site is the same. It's the QDM issue tracker hosted by the Office of the National Coordinator. And Jess can add that specific link to that site in the chat as well, so that you guys can bookmark that.
Wonderful, thank you. So it looks like we have a couple of additional questions coming in. And I also want to point out that Jessica Sadler just posted the FHIR specification feedback as well as the QDM issue tracker in the chat. So those were both available. So for the our second question, or third, is are new eCQMs being developed for use in CMS programs supposed to be specified using the FHIR-based standards, or is CMS only focusing on existing eCQMs to FHIR-based standards?
Great question. CMS has publicly indicated its intent to move to FHIR-based standards. CMS is currently focused on converting the current program eCQMs to FHIR-based standards and integrating new eCQMs into this conversion and FHIR implementation process as they are submitted to CMS. For example, for this year's call for measures, CMS requested all submitted eCQMs include both the QDM and FHIR-based measure packages, if available, to ease the integration of the new eCQMs into the ongoing conversion efforts. We encourage anyone working on an eCQM to be specifying it in both QDM and FHIR standards as we move forward.
And Lisa, while I have you on, there is a question. If you could explain the difference between eCQMs and FHIR and dQMs?
Yes, so eCQMs and FHIR, that's kind of what we're talking about when we talk about the current eCQMs that are getting converted to FHIR. They're pretty much a one-to-one match to what the current eCQMs have. Where dQMs come in, it kind of expands upon what we're currently getting from eCQMs. So it goes back to those additional digital data sources that Grace mentioned earlier in the presentation, where there's opportunity to get things like administrative data or claims data. And I'll specifically talk about claims data. So in the quality data model, there's nothing in that data model that lets us get to claims information. However, in QI core, there is the ability to get to claims and claims response and some other things that you might want to get to if you're trying to specify a claims-based measure and have it kind of match up to what you have today. So I hope that helps.
Awesome, thank you so much. And it looks like we don't have any other questions in the Q&A, so I can move it along to the next slide. So I did want to draw your attention to an update announcement. CMIT 2.1 is coming soon. So the CMS Measures Inventory tool is improving to enhance your experience. We are going to be rolling out updated terminology, IDs, new features and content, and we're going to ask that you join us for a webinar on March 29th at 2 p.m. Eastern Time to learn more, and it will include a live demonstration of some of the new components. So if you look in the chat, we have the Zoom link to register. And we really look forward to you joining us then. And then our next slide. So here you have our contact information, MMS support at patel.org for any questions. We also have our CMS leads contact information on here. If you have additional questions about the measure lifecycle, specifically the specification phase, which we discussed today, we strongly encourage you to visit mmshub.cms.gov. Really want to thank our speakers, Lisa and Grace, today for such a wonderful presentation, and all of you for joining us. So thank you all and have a wonderful rest of your day.